Wow, so this is pretty amazing. We had this idea that we would hopefully partner with Bobby Jones and develop really a patient-centric, series of talks, and because this is how we learn. And so what I hope to convey to you today is that among all the other stuff that we do is our commitment to the patient population, and how the simple act of listening can really change the trajectory of this disease that you all experience. So I want it to be positive, optimistic, and provide some hope. And so what I'm going to do is I'm going to present to you some data that we haven't published yet. Some of it has been in preprint form about genetics, and then Dr. Gensimer will come up and talk about some biomarker stuff. But I want to start with really some unanswered questions. And I get asked a lot, how do we choose which research area to follow? How do we know which questions to ask? It's a good question because we don't know hardly anything about Ehlers-Danlos syndrome, hypermobility type. And so the way we go about this is we ask the patients. So what you see here, I don't expect you to read this. I can't even read it. So in my lab, I have a large glass board that any patient who comes in, or a member of a family who's affected, we ask them to write down their questions. That's our starting point. That's how we know what questions are important to ask. You can't, or to answer. You can't always read a textbook to really know which questions are the right questions that need answering. So we go to the patients. And this is just an example. So this board has been filled up, I don't know, Molly, 10 times or 5 times or 5 or 6 times. Erased, taking pictures so we know what the questions are, and then we compile those and try to boil those down and say, okay, what are the questions we really need to focus on? Recognizing that there are so many questions that you guys have. And so we really wanted to start with, what is hEDS? When you look in the literature and you look at the 2017 criteria that was written by the EDS Society, you recognize that patient voices are really not very well represented. And so we wanted to get a better definition of what hEDS is. And that's really important because that can help guide clinical diagnostic guidelines. You guys know what hEDS is, right? It's a question, right? Yes, right. However, physicians who you see, for the most part, do not. And there are some very talented physicians who listen, but the vast majority of physicians do not. So we need to understand and publish data from you guys, from your self-report and also from clinical reports that define what this disease is. Are there molecular diagnostics that can help in that journey? And are there therapies? So what is hEDS? And can we provide a guidebook or a roadmap for the physicians to actually take to understand what this is? And so we've recently published as a preprint. I invite you guys all to look this up. If you need help downloading it, you can reach out to Molly Griggs. And we'll be happy to send you a copy of it. It talks about really a global survey. And I'm just going to take you through a few highlights. This is on almost 4,000 patients. So it's the largest global self-report set of clinical diagnostic criteria that has ever been published. You'll see down here on the bottom right all the different areas in the world that this is represented. And just a few highlights. These things are things that you know, but these things are things that physicians don't. So always keep that in mind. Average age, 26 to 44. And we also did hEDS versus HSD. And then, And then obviously the female predominance of the disease is really significant, which we all have known about for some time. The diagnostic timeline. Since this is the largest clinical report so far to date, this is probably the most representative of real data. And you'll see that for hEDS, 22.1 years to diagnosis. That's bananas. It's crazy. Symptom onset, 9.3 years of age versus HSD is 12.3. 60% of hEDS reported misdiagnosis. Wow, these things need to change. And if you look at this, there's a lot of data here, but if we just look at the top, this is the number of comorbidities, co-occurring comorbidities. On average, hEDS patients have 25. It's incredible. And if you look at the top three, I'm not even sure I can read that. What is interesting in this is that joint subluxations and dislocations is not actually one of the top three, which was interesting to me. Chronic pain, autonomic dysfunction, and GI. Okay, these things are really interesting in the context of a classically defined connective tissue disease. And it's sort of maybe we need to rethink some aspects of this disease and how we define it. And on those lines, triggering events. This is what really made me think hard about what this disease really is. 70% of those with EDS report a triggering event. Something that after they got this trigger, they became worse, or it revealed new phenotypes. Could be Epstein-Barr, something we hear about a lot. Mono, puberty, accidents, and those sort of things. But this is really interesting because this says, hey, maybe there's more of an immune response than we were previously giving credit for. So as I said, you can read that paper. It's available online. I encourage you to all read the paper. Give me feedback. This is a survey from patients, so let me know what you think. So this will hopefully, and the paper is 81 pages long, just to give you a little warning, because it was almost 400 questions and you 4,000 people responding to 400 questions. You have a ton of data but it's important to define it, right? So this is going to lead to a better definition. We're working then with other physicians to actually validate, including Dr. Lavalley, who's here, to validate some of these self-reports in smaller cohorts, and then redefine the clinical diagnostic criteria on real numbers, on real metrics. This has really brought in my mind is hEDS really a subtype of EDS? And we can talk more about that. What's up with the triggers? Pain, GI, autonomic function, immune, mast cell problems are so central to this disease that maybe they're a driver and the connective tissue is a consequence. Can genetic and blood markers provide additional clues to this question, to answer this question? Oh, went the wrong way. And so many of you know that we identified a gene a couple years ago. It's in the kallikrein family. This has also been, is out there in print. Started with a large family with inherited hEDS. We did whole exome sequencing, so we sequenced everything that makes a protein. And then we identified one variant that tracked with the family. I'm not going to spend a whole lot of time on this because it's out there. Many of you have probably already seen this paper. We've identified it in multiple families, and we've also identified that the gene mutations are enriched in hEDS patients compared to controls, and the whole gene family and the whole kallikrein gene family. We generated mice that actually validated the phenotype, so we feel pretty strong that this is actually a causative factor in hEDS, but it's going to be a small contributing factor. So these KLKs or kallikreins are likely involved in the pathogenesis of the disease. The mice do have structural as well as immune dysfunctions. and also connective tissue mechanics are changed. But this is really a minor contribution. This is not going to be everybody in hEDS having these mutations. We know that it's going to be polygenic. Polygenic means that multiple genes, multiple gene SNPs or mutations can work together in concert to then cause the disease phenotype. So the way to identify those is through large population genetic studies. Okay, so these are in thousands of patients. This is similar to what the EDS Society is doing it with hEDS, and we're doing it. We've also completed this study now for our GWAS. And so just to simplify things, GWAS stands for Genome-wide Association Study. And you basically take a group of EDS patients right here, and you take a group of controls, and you do genotyping. There are genotyping arrays, and these are looking for SNPs or single nucleotide polymorphism all throughout the entire genome. And then comparing them between the two populations and saying, is there a change in the genome that is enriched in patients with EDS? And you get these plots like are down here at the bottom. It's called a Manhattan plot. And so I just want to give you sort of a context of how these studies work. For us, it was 3 case control studies. So the initial case study had 860 EDS patients, 2,500 controls. The second had 493, 1,300. And then we used the All of Us data set from NIH, which is a sort of a national registry, where we identified another 460 cases and another 1,300 controls. Then we do a lot of fancy things that are complicated to describe, which is why I have population geneticists working on this. And in the end, we get GWAS signals, so genome-wide association signals. And this takes about 2 years. So one slide, which gives us this, took 2 years. But what's exciting about this is that we identified 2 SNPs that are significantly enriched in the EDS population compared to controls. Labeled SNP1 and SNP2. We haven't published this yet, so I can't let you know what these genes are. I can tell you what they do, and I think you might be a little excited. But I hope you are. So yeah, a lot of work goes into this. Now, we can then take and do another fancy statistical test called a GBAT analysis, which looks at whole genes. And from this, you'll see the little arrowheads pointing to little dots. Those represent individual genes in the genome where there's an enrichment in changes in an EDS patient compared to a control. And so when you take these things all into consideration, we've now identified 11 new genes for hEDS. It's pretty good. So what do some of these things do? So, if we go back and this guy right here was really interesting. So then you have to prioritize. You have to figure out which ones you're going to look at first. We obviously want to look at all of them, but we have to prioritize. And so when we look at SNP1, this is what SNP1 does. This is the gene that it regulates, and you'll maybe recognize some things that are really relevant. Pain, neuroinflammation, anxiety, depression, blood pressure regulation, GI dysfunction. There are some sort of minor connective tissue issues and inflammation, including mast cell function. So these SNPs in this gene are dysregulating a gene that regulates all of these things. I think that's really powerful because this gene can be drugged. So we've identified gene loci associated with pain, GI autonomic function, inflammation, as well as blood clotting. We really don't see any strong signal in any of our genetic or our biomarker work that is directly related to structural or connective tissue genes. This makes us really think, well, that's interesting, and sort of supports the patient-reported data that maybe this is being driven not as a collagen primary problem, but that the collagen is a consequence. Why is that important? It's important because when you develop therapies, You want to know what your primary problem is. Maybe you're making collagen, maybe your collagen is just fine. So getting more collagen isn't going to help. You have to figure out why it's being destroyed. Some of these are druggable. The lead one, that's SNP1, is druggable, and that's what we're working with some companies as well as AI technologies to develop smart drugs to be able to target this. What about blood markers? Stay tuned for Dr. Gensimer's talk. She's going to be up after me and can tell you all about what she's found. So is hEDS primary connective tissue disease, or a disease rooted in autoimmune dysfunction or autoinflammation or both? I'm leaning towards the latter because that's what the genetics and the biomarkers and patient reports are all telling us. In the end, how does the patient, this is what I always get, and I'm sure it's some of you are thinking, how is this going to, how can we benefit? How can the patients benefit from what we're doing? How can we translate our discoveries? And so I just wanted to present as the last slide of my talk, sort of our research and clinical care roadmap. I think this is really important. So this is how I think about it, and don't hold me on the dates. This, please. These are moving targets. So we wanted to find the biological basis of EDS, of hEDS, and define the clinical spectrum. I think we're doing that, and I think after these papers come out, we'll have a much better idea and understanding of hEDS. We're launching mechanistic studies of the whole exome and the GWAS hits, those SNPs that I defined. So that's ongoing, that's happening now. Some of it's already been completed and just waiting for publication. We need to develop better diagnostic tools. And I think we need to pair sort of new diagnostic guidelines that we'll get with the phenotyping data, with polygenic protein-based and triggering risk scores. So we need to be taking everything into consideration for these patients to really make a more accurate diagnosis. We are using AI and drug repurposing to generate new therapies. And these will include antibodies and AI-generated antibodies and small molecules. So this will be in the next year or so. Those will go into preclinical testing and launch a first therapeutic trial in the next year and a half to 2 years. And then we need to integrate these with electronic health records, genetic, blood, and clinical phenotyping to really develop a precision medicine approach, because everybody with EDS is a bit different. So at the same time, when we're doing all of this, we have an amazing patient scientist program, and Molly is going to be talking maybe about some of this, to invite patients to come into the lab and be part of be change makers. Physician education, this needs to happen at all levels. We're doing that, and due to time, I can talk to you guys later. And that includes a meeting with AAMC. And then, of course, we need to engage Congress and NIH to do research priorities. This work is really only possible through the establishment of the EDS Center at MUSC. You need the integrated care team, the physicians, the scientists, and the educational aspect to really make these changes. We're trying to make this happen at other institutions. This needs to be regional. There needs to be, one of these things in every state, the same as there is with cancer institutes, cardiac institutes. There needs to be these multidisciplinary clinics and surgical opportunities for patients everywhere. Nothing of significance happens alone. And this is my group. It's large and difficult to manage sometimes. I don't know, 70% of these people in the picture have EDS themselves, so we learn from them. And I just want to, one more last slide. Let us not forget how this started. I'm just a dumb scientist. I rely on really smart patients to tell me what to do. And this started 6 years ago, maybe coming on 7, with Courtney. So listening to patients can change everything. Thank you for your time.
We can take about 2 questions. I'm pretty glad I'll do it. Anyone have? Go ahead.
How do we get involved in the clinical studies?
It's a good question. We're in the process of revising a lot of our IRBs, and with Ann Maitland coming on as our medical director, she is here somewhere, I'm assuming, right there. She can maybe talk more about when her clinic is going to be open, and then at that point we can. I'm getting the. You can reach out to me, and I'll see how I can help navigate those. Because we didn't have time to go through all the different clinical studies. We're basically in every discipline, so neurosurgery, GI, derm, allergy, immunology, ortho, as well as PT, OT. And of course the genetic studies and the molecular studies. So there's a lot of different opportunities. And so maybe I should put something together on how best to. See, I've learned. Thank you for that question.
Have you been affected by the recent cuts to NIH?
Yes, unfortunately we have. There was a grant we had at NSF, National Science Foundation, that was to really empower patients. It fell under a DEI initiative, and that whole grant disappeared literally overnight. $2 million gone. So, and all the other grants that we have through NIH have been significantly cut in half almost. So the studies you've seen have been due to the kind donations of philanthropy, and that the donors are really. The donors and the patients are really what's driving this engine. So, sadly, yeah.
That was a very good question.
Yeah.